you know, is the largest solid clamp, weighing about 1300 to 1600 grams. It lies in the right hypochondrium, epigastrium, and the left hypochondrium, extending up to the left lateral line. The gallbladder lies embedded in gallbladder fossa liver, fundus of the gallbladder projecting beyond the cystic notch, lying in direct contact with the anterior abdominal wall at the level of the tip of the ninth costal cartilage. The liver and the gallbladder, they develop in the ventral mesogastrium from an endodermal hepatic bud arising from the ventral border of the distal end of the foregut, proximal small part of the known as pars cystica. So this endodermal hepatic bud divides into two parts: a proximal smaller part known as pars cystica, which forms the gallbladder, and a cranial larger part known as pars hepatica, which forms the liver. Here in this dissection, you can see the liver in situ. You can see here the right dome of the diaphragm, the anterior abdominal wall, and the upper lower part of the thoracic wall has been cut and removed. Here you can see the heart includes the pericardium. This is the right dome of the diaphragm. This is the left dome of the diaphragm, and here you can see this liver lies below the right dome of the diaphragm in the right hypochondrium, in the epigastrium, and extends, the left dome extends up to the left lateral border. Now, left lateral line. Here what you can see is the falciform ligament, which is a peritoneal fold developed from the ventral mesogastrium, lying between the liver and the anterior abdominal wall. So this is a double layer of the peritoneum. Here it has got a fixed margin attached to the anterior abdominal wall and a free margin, here you can see, which lodges the ligamentum teres. This is what you can see is the stomach, the greater curvature, the lesser curvature, the lesser omentum, and here you can see is the greater omentum. This is what you can see is the transverse colon. This is the transverse colon, and these are the coils of the jejunum. This is the inferior border. This is the inferior border of the liver, which is sharp and well defined. And here what you can see is the anterior surface. Now, here what you can see, there is a notch here in the inferior border known as cystic notch, and below this you can see is the fundus of the gallbladder. This green color, and here this fundus of the gallbladder covered with the peritoneum lies in direct contact with the anterior abdominal wall. And here you can appreciate that this liver, as it lies below the right dome of the diaphragm, it moves with the respiration. So a hepatic lump is differentiated from the lump in the right hypochondrium. If this is a enlargement of the liver, it moves with the respiration, while the other lumps here they does not move with the respiration. We, and this fact is taken into account for palpating the liver. We put the palm of the hand on the anti-abdominal wall in such a way that the tip of the fingers they are directed upwards, right and to the right, and we ask the patient to take the deep breath. The liver is felt at the tip of the fingers during inspiration. Normally, the lower border of the liver does not extend beyond the costal margin. Now, there is another notch here. This is the notch for the ligamentum teres. Now, coming to the lobe border and surfaces. Anatomically, liver has got two lobes, a right and a left. Right lobe is larger and the left lobe is smaller, and they are separated on the anterosuperior surface by the falciform ligament. The fissure for the ligamentum teres lies inferiorly, and fissure for the ligamentum venosum lies posteriorly, and this separates the right and the left lobe anatomically. The liver has got five surfaces: anterior, posterior, superior, inferior, and right. It is only the inferior border which is sharp and is well defined. All the other borders are rounded. The falciform ligament consists of two layers of peritoneum extending from the anterior surface of the liver to the anterior abdominal wall. It is derived from the ventral mesogastrium. Here you can see the anterior surface of the liver. This is the anterior surface of the liver, and here you can see is the attachment of the falciform ligament, which superiorly that falciform ligament has got two layers of the peritoneum, and these two layers they get separated superiorly here. This is the right lobe, and the right border is rounded. Here this is the inferior border, and this inferior border this is sharp and well defined, and this inferior border here you can see it has got the notch, that is the cystic notch, and here you can see the gallbladder which extends beyond the cystic notch. The whole of the liver is covered with the peritoneum except for the bare areas which we'll discuss in later. And this is the notch here. This is for the passage of the ligamentum teres, and this separates the right and the left lobe anatomically. The inferior border is sharp and well defined, a cystic notch and a notch for the ligamentum teres. It separates the anterior surface from the inferior surface. So the inferior border separates the anterior surface from the inferior surface. The ligamentum teres is a derivative of obliterated left umbilical vein. This left umbilical vein in the fetal life carries oxygenated blood from the placenta to the inferior vena cava. The ligamentum venosum is a derivative of obliterated ductus venosus. This ductus venosus is a venous channel, which transfers oxygenated blood from the left umbilical vein to the inferior vena cava because in the fetal life, liver is not functional. After birth, the lungs and liver they become functional. The oxygenation now occurs in the lungs instead of placenta. So the left lumbilical vein and the ductus venosus becomes obliterated. Now the bare areas of the liver. There are four bare areas. Main bare area is the triangular bare area on the posterior surface of the right lobe. It is limited by superior and inferior layer of coronary ligament and by right triangular ligament. The common site of collection of the pus in the subhepatic abscess which is usually amoebic in nature. So this triangular bare area, this is the largest bare area. This is present on the posterior surface of the right lobe and it lies between the superior and inferior layer of the coronary ligament and by right triangular ligament. Developmentally, the liver grows superiorly very faster and comes in contact with the septum transversum, which develops later and develops into the diaphragm. So the liver lies in direct contact with the diaphragm. So this bare area is the common site for the collection of pus in the subhepatic abscess. And this hepatic axis is usually amoebic in nature. Another site of bare area is a groove for the inferior vena cava where lodges the inferior vena cava. The fossa for the gallbladder. Now, the gallbladder lies in the fossa for the gallbladder in the right lobe of the liver and it is separated only by the loose connective tissue and hence lymphatics from the gallbladder directly pass to the liver, invariably spreading the carcinoma of the gallbladder. So, this is very common. The carcinoma of the gallbladder is quite common disease, and if there is a carcinoma of gallbladder, the secondaries they pass into the liver very frequently. So much so that even if the secondaries are not seen in the liver on ultrasonography or on the CT scan, even then we assume that some microscopic spread must have occurred in the liver. The area for the attachment of the lesser momentum and groove for the ligamentum venosum is another site of bare area of fever. Here you can see the inferior surface of the liver. You can see here the inferior border. This is the visceral surface. This area here is the bare area. This is the bare area of the liver. This is the groove for the inferior vena cava. And here what you can see, this is the caudate lobe of the liver. And this is the caudate process. Now, this is the porta hepatis, through which pass the hepatic artery, the hepatic ducts, and the portal vein. This is what you can see is the quadrate lobe. This is the ligamentum teres. This is the ligamentum teres or the round ligament. Now, this is the gallbladder you can see present in the gallbladder fossa. You can see the gallbladder present in the gallbladder fossa. This is what you can see is the cystic duct here. These are the hepatic ducts, and this area you can see. This is the area which lies in relation with the right kidney. This depression here, and here you can see the peritoneum from the anterior surface of the kidney reflects on to the right, reflects on uh, to the liver here, and this is the superior vein area. So this is the area which lies in relation with the left, with the right kidney. This area here, you can see, lies in relation with the stomach, and this area here, you can see, lies in relation. This is the area in relation with the stomach. Now, here, this is the liver seen from the posterior surface. You can see the left lobe. You can see here the right lobe. This is the groove for the inferior vena cava, and this is the right and left hepatic veins. They are opening directly into the inferior vena cava. This is what you can see is the caudate lobe, and this is the caudate process, and this is the fissure for the ligamentum venosum. This is the fissure for the ligamentum venosum. Here you can see the superior and the inferior layer of the coronary ligament. And here the two layers are joined to form the right triangular ligament. So, so here is the right triangular ligament, and the two layers of the falciparum ligament. They separate here, forming the right triangular ligament, and which is continuous with the superior and inferior layers of the coronary ligament. And here you must appreciate that this coronary ligament not lies in a single plane. The lies superior layer of the coronary ligament lies superiorly here, lies on the superior surface of the liver, while the inferior layer here, it lies here posteriorly, extending up to the inferior surface. And this bare area, main triangular area, is present posteriorly and inferiorly. So superiorly, posteriorly, and inferiorly. The hepatic segments. On the basis of the intrahepatic distribution, a hepatic artery, the portal vein, and biliary ducts, the liver can be divided into right and left functional lobes. These lobes are separated. They are also known as physiological lobes, and they are separated by a plane passing on the anterosuperior surface along a line joining the cystic notch to the groove for the inferior vena cava. On the inferior surface, the plane passes from gallbladder fossa, and onto the posterior surface, it passes through the middle of the caudate lobe. The right lobe is subdivided into anterior and posterior segments, while left lobe is divided into medial and lateral segment. So that way there are four segments, two each in the right and left lobe. In the right lobe they are anterior and posterior, and in the left lobe they are medial and lateral. And they are accompanied by each segment is accompanied by a branch of the hepatic artery and portal vein, and the um, biliary duct. So there are three structures present here: the hepatic artery, the branch of the portal vein, and the biliary duct. As far as the hepatic vein is concerned, hepatic vein runs into the intersegmental plane. These segments are important surgically during resection of the liver and in hepatic transplantation. So nowadays it is possible to resect a diseased segment of the liver and to transplant a part of the liver, a segment of the liver, into another person whose liver is not functioning due to any disease. Porta hepatis. This porta hepatis is a sharp transverse fissure about 5 centimeters long. It is situated on the inferior surface of right lobe of liver. It lies between the quadrate lobe above and the quadrate lobe below and in front. The portal vein, the hepatic artery, and the hepatic plexus of nerves enter liver through the porta hepatis, while the right and the left hepatic ducts and a few lymphatics they leave it. The relations from behind to forwards are the portal vein, the hepatic artery, and hepatic. So if you see the structures in the porta hepatis from behind forwards, they are the portal vein, the hepatic artery, and the hepatic ducts. The lips of the porta hepatis they give attachment to the lesser omentum. This dissection has been done to see the structures present in the porta hepatis. Here you can see the portal vein. This is the portal vein, this is the hepatic artery, and this is the bile duct. This there are two hepatic ducts, the right and the left, coming from the right and left lobes of the liver. The two ducts they join to form the common hepatic duct. The two right and left hepatic ducts they join to form the common hepatic duct. This common hepatic duct, here you can see the cystic duct. The cystic duct joins the common hepatic duct at an acute angle to form the common bile duct. So this forms what is known as the extrahepatic part of the biliary system, which consists of right and left hepatic ducts, common hepatic duct, then cystic duct joining the common hepatic duct to form the common bile duct. Here what you can see is the gallbladder embedded in the gallbladder fossa, and here you can see the cystic artery which divides into two branches, a superior and an inferior, and supplies the gallbladder. And here you can see the cystic artery that is passing between the gallbladder and the substance of the liver in the gallbladder fossa, embedded here in the loose connective tissue. Here the part of the hepatic tissue is removed to expose these structures. This is the what you can see is the this is the common hepatic artery. This is the common hepatic artery. It is a branch of celiac trunk. This is a celiac trunk taking origin from the abdominal aorta. Celiac trunk is very small, about a centimeter in length. It divides into three branches: the left gastric, the common hepatic, and the portal. And the splenic artery. This is the common hepatic artery. Yes. It gives the gastroduodenal branch, and then it becomes the hepatic artery proper. This hepatic artery proper runs upwards in the right free margin of lesser momentum, anterior to the portal vein, and the bile duct line meet anteriorly and to the right. Here you can see the common bile duct. This is the cystic duct. This is the common hepatic duct. So this hepatic artery divides into two, a right and the left branch in the porta hepatis, and respectively it passes into the right and left lobes. So here you can very well see the right branch, this is the left branch. Here you can see the portal vein. Yeah, it lies posterior. Also dividing into two, right and the left branch. And these branches they accompany the corresponding branches of the hepatic artery and the hepatic duct. The gallbladder is a pear-shaped reservoir of bile situated in the fossa on the inferior surface of right lobe of liver. It consists of fundus, body, and the neck. Fundus projects beyond the cystic notch in the angle between the lateral border of the rectus abdominis and the ninth costal cartilage, and lies in contact with the anterior abdominal wall. This relation is very important because in the acute cholecystitis, when a finger is placed on the tip of the ninth costal cartilage, the patient feels sharp pain on inspiration and holds the breath, and this is known as Murphy's sign. So this is the Murphy's sign, the clinical sign diagnostic of the cholecystitis. The pain of the stretch of the gallbladder is referred to the epigastrium, to the right shoulder, and to the inferior angle of the right scapula. The fundus, as I have already shown you, is entirely covered with the peritoneum, while body and the neck is covered only on the inferior surface. The superior surface of the body and the neck lies in direct contact of the liver in gallbladder fossa, separated only by the loose connective tissue in which are embedded the cystic vessels. Hence, the carcinoma of the gallbladder almost invariably spreads to the liver by lymphatics. The neck is the narrow upper end of the gallbladder, situated at the right end of the porta hepatis, and is continuous with the cystic duct junction of the cystic duct, and the neck is marked by a constriction. The posterior medial wall of the neck is dilated to form the Hartmann's pouch, where gallstones are often lodged. The gallbladder develops from the parasistica of the endodermal hepatocystic part. Here you can see the dissection for the hepatic artery. You can see this is the common hepatic artery. It is the gastroduodenal and becomes the hepatic artery proper, runs in the right field margin of lesser momentum. Here you can see on its right lies the common hepatic duct and the bile duct, and here lies the posteriorly lies the portal vein, which here in the porta apparatus divides into the right and the left branch. Hepatic artery proper also divides here into right and left branch, accompanies the right respective branches of the portal vein and the hepatic duct. This is what you can see is the head of the pancreas, known as, which projects above the um, lesser curvature. This is known as tuber omentale. This is what you can see is the right gastric artery and the right gastroduodenal artery is the right gastroduodenal, which gives the right gastric branch, which anastomosis with the left gastric artery along the lesser curvature. This diagram is of oral cholecystography. You can see here the gallbladder, very well seen. This is the fundus, the body. This is the neck of the gallbladder. You can see, and here you can see the stones in the gallbladder. This is the case of the poly. This stone in the gallbladder is known as polylithiasis. So the gallbladder can be visualized radiologically by putting a dye either orally or through the intravenous. And this dye, which is opaque, and it is secreted in the bile and concentrated in the gallbladder, and the gallbladder is very well visualized. Here you can see the gallstones, which are usually cholesterol stones. There are three types: either cholesterol or bilirubin, or third is the mixture. And most common is the cholesterol, and they are normally radiolucent. And so, in normal diagrams, they are not seen. They can be visualized on cholecystography. This is to the liver and the gallbladder. They has been visualized on ultrasonography. Here you can see the gallbladder. Here you can see the stones in the gallbladder. So gallbladder and the stones in the gallbladder can be very well visualized on ultrasonography. We also visualize the liver, the liver. So that is all about the liver and gallbladder, its peritoneal flexure. its blood supply, and the extrahepatic biliary apparatus and applied an